The NAPNAP admin group is going to post the slides for me, so you'll be able to see all of the things that we are talking about. I was hoping to have slides today, but we weren't able to get them up and running, so you'll be able to reference them when we are done. So before we talk specifically about breastfeeding or utilizing breastfeeding to mitigate pain during routine infant vaccination, I thought it would be a good idea for us to just quickly review the benefits of childhood vaccination in reducing the burden of disease, morbidity, and mortality. It's one of the most cost-effective manners, and it's a very well-established public health campaign to administer vaccines to our pediatric patients. Vaccination helps to avert associated out-of-pocket medical expenses, healthcare provider costs, losses in wages for parents, patients, and caregivers who have to miss school or get out of work in order to see the pediatric provider. We do know that vaccinations or injections are the most common source of iatrogenic pain, and that's what we're going to focus on today because it's estimated that about 25% of adults have a fear of needles, with most fears developing in childhood. A majority of children exhibit needle pain or needle fear. You can reflect on your clinical practice and sort of think about, the infant does not know, the toddler gains quick realization that every time they come into the office, they're likely to get poked in one way. And then, of course, the school-age child wants to know when they walk in the door, are they going to get a shot? And so, of course, we all have to manage expectations and provide some guidance and be honest with our patients so they can anticipate how they're going to respond. About 20 to 50% of adolescents and 20 to 30% of young adults have a fear of needles. And because of this, about 10 to 15% of the population avoids vaccination and other needle procedures because of their fear. And we definitely saw that during COVID in terms of vaccination hesitancy. As medical providers, we have an obligation, primum non nocere, which is the importance of pain avoidance in the delivery of healthcare, to first do no harm. And so we are obligated to of course, consider this in our practice. So, how do we reduce pain during routine vaccination, and what does the evidence tell us? I'm going to talk a little bit about the evidence, and when you have access to the slides, you will see on slide 6 that I outlined the criteria for evaluating evidence and for grading recommendations. So we have level of evidence, and then we have a grading of the recommendation. So for an example, evidence 1 or level 1 evidence is evidence from randomized controlled trials, and that goes down to 2, to 1, to 2, to 3, and then 3, with of course 1 being the highest level of evidence. And then we have recommendations A through I. A is there is good evidence to support this recommended action. E is there is good evidence to recommend against the action, and that's important as we talk about some of the positioning of infants during vaccination. And then of course we have I, which is there's insufficient evidence or data to make a recommendation one way or the other. So when we look at the evidence in terms of how could we reduce pain, there are 3 sort of highlighted key points for us to take home or to bring back to our practices. 1, to reduce pain during the time of injection, we need to encourage breastfeeding mothers or lactating parents to breastfeed their infant during vaccination. And this is a grade A recommendation based on level 1 evidence. So this is very, very high evidence. If a parent is not breastfeeding, then we need to provide ethically an alternative option that also has high level of evidence to support this recommendation with a grade A, if possible, recommendation. And this is administering Sweet Ease or sweet tasting solution during vaccination. This is essentially sugar, and that has been shown to be equally as efficacious to reduce injection associated pain. So that is something that a practice can implement in terms of changing the administration of vaccines. The Sweeties solutions are not expensive, but again, this is implementing a change in practice unless some of you are already doing this in your practice. And then lastly, when we talk about reducing pain as far as positioning the infant, we actually know that we should not place infants supine for vaccination. And so this could be on a changing table, this could be on an exam table, and there is high level of evidence, so those randomized controlled trials looking at pain scores, and it's a grade E recommendation, which is there is strong evidence to support against putting an infant or lying an infant supine. And this really is known to heighten the sense of anxiety or pain. And if you can sort of imagine an infant lying on their back, oftentimes with arms being restrained so they don't interfere with the provider or the nurse or the NP who is giving the vaccine. And so that level of restraint often heightens the level of anxiety as well. So, again, reinforcing breastfeeding during vaccines. And what we should do, what we recommend is we actually want the parent to latch the infant for a few minutes prior to vaccine administration. We want the feeding session to be well established before the first injection. So this may take a couple of minutes. That of course is a balancing measure that we have to consider when we're changing practice or we're introducing something new in a practice. Some infants may refuse to breastfeed. Some lactating parents or mothers may opt to not breastfeed, but offering breast milk in a bottle or offering formula in a bottle is not considered a substitute for breastfeeding as a method of reducing pain. I often get that question. There's no reports of an infant gagging or spitting up during breastfeeding or during vaccine administration while breastfeeding. The infant may pop off of the breast and come back to the breast. For those who administer rotavirus at the beginning of the vaccine sequence, then this has to be given at the end. So that may take a couple more minutes if the infant is upset. So again, thinking about the sequencing of that administration at that visit. Sucrose solutions, as I mentioned. And then again, if a patient or a parent does not want to breastfeed and we do not have the option of a sucrose solution, we can position an infant on the parent or caregiver lap and the infant can be held. So those are alternatives. But the key point is also remembering not to place the infant supine or on their back during vaccination. So that's positioning, and it's good to sort of review the evidence, and when you look at the slides, you'll be able to access that. We also need to consider administration technique. I want you all to reflect on how you learned or how you were taught to administer a vaccine and what you need to demonstrate when you are in a clinical practice. And we think about the IM injection and pulling back or aspirating prior to administration of the vaccine. And actually, to reduce pain at the time of injection, we recommend administering intramuscular vaccines using a rapid injection technique without aspiration. So this is high level of evidence supporting this, but it's a grade B recommendation. And so our grade B recommendation is there is a fair amount of evidence to recommend this versus a good amount of evidence to support the rapid administration. When administering multiple vaccines to children sequentially, you want to inject the most painful or the more painful vaccine last. And so, what are the painful vaccines? That's our Prevnar and that's MMR. It's also HPV, but infants and toddlers are not receiving HPV, but just for your education, HPV is included. But when we think about infant and toddler vaccines, we think about Prevnar and we think about MMR as being the more painful injections. So we want to administer that last. And if you have a combination vaccine, depending on your practice, the one that contains that should be administered last. So just keeping that in mind. And, again, when we think about, MMR can be given sub-Q or IM, and varicella, polio, Prevnar are sub-Q, but can be given IM, especially if they're a part of a combination vaccine. So we want to we want to have a rapid injection technique. We want to administer the more painful or most painful vaccine last. And for children who are age 4 years and older, we want to offer to rub or stroke very gently the skin near the injection site before and during vaccine. So not on the site, but around the site. And that's sort of the same concept of using shot blockers that we actually, they're sort of shaped like a little horseshoe, and the needle goes right in the center, and the shot blocker has little teeth. And that's a similar type of intervention where we are sort of tricking the brain and we are providing tactile stimulation to help mitigate pain. And lastly, in terms of administration technique, it is acceptable to use a topical anesthetic during vaccination. If you're in the United States, to get a topical lidocaine like an EMLA, you need a prescription. But Recticare is actually 5% lidocaine available over the counter. If you're in Canada, parents can get a topical anesthetic over the counter as well. So knowing what's available is helpful when you're making recommendations. And then many offices have a spray anesthetic that is often used in the older patient. Up to age 15 is the recommendation. So when we talk about distraction, it's important for us to differentiate and to know what the evidence tells us in terms of what type of distraction is effective to reduce or mitigate pain. So parent-led distraction in coaching, there's actually insufficient evidence to support for or against this style. Clinician-led distraction techniques during vaccination of children is actually a grade B level of recommendation, a level 1 and a grade B, so more effective. And to reduce pain for children 3 years of age or older, you can use child-led techniques. And then lastly, children who are 3 years of age or older can engage in deep breathing techniques, more of the mindfulness. Now, of course, as a tech society, there's apps that are very, very helpful to guide the patient, but really need to be that preschool age in order to follow those directions and engage in that. So distraction is really the only psychological intervention that's been examined in guidelines that can be employed by children. So just at a snapshot, when we talk about techniques or strategies to reduce pain, we think about injecting the least painful formulation. We want to position the infant on the breast or position the infant upright, being held rather than supine. We want to stroke the skin around the site of the injection, and we want to sequence the injections where the most painful vaccination is administered last. And we want to perform rapid intramuscular injection without aspiration. So I would love and welcome some input from those of you in the audience to share with us who administers vaccines in your practice. Is this done by the provider? Is this done by the nurse? Do we know what their training was in terms of vaccine administration? How is the child or the infant positioned in your practice? What is the standard in your clinical setting? And what do you currently use in terms of pain reduction techniques or strategies in your practice? So happy to have people discuss this. Happy to take questions, open this up for comments. So let's see how I can see comments. Let me go here. Okay, I have a couple reactions here. One comment. So I guess, I'll stay on for a couple more minutes. One of the things we did when I came to my practice about 10 years ago is most of the patients were placed supine on the exam table for vaccines. And we've been able to get them off of the exam table and into parent laps or onto the breast of those parents who are moms who are breastfeeding. And so I, of course, would be happy to engage in more conversation about that or email. Perhaps I just will put my email in the chat. And if anyone, edu, sorry about that. Anyone has any questions, you can certainly send them my way. Great. Do apologize for being a little bit late. I see that there's a few people on. So if you have any questions, I think we just had someone join us a little bit late, but we have been discussing utilizing breastfeeding to mitigate pain during routine vaccination. An alternative is holding the infant or providing a sucrose solution, which is fairly comparable to breastfeeding. Bottle feeding with breast milk or formula is not an appropriate substitution. Rapid administration of vaccines using provider-led distraction techniques, and sequencing vaccines where the more painful vaccine is administered last. So if there are no other questions, I'll end our live session. Thank you again for your attention and for tuning in, and look forward to the next time.